one of the first tests for this was the 70 gene profile. This test is from the technique is very simple because you get the gene expression profile and you use biomathematical approaches to classify or to cluster this gene expression into different clusters, and what you come out with is a gene expression cluster that puts you in a good or in a bad prognosis group. And if you want to establish a prognostic profile, then you can change the line where you say it's a good prognosis or it's a bad prognosis group, and then you either enhance specificity or you enhance sensitivity, whatever you want, and you can search for the best cutoff to do so, and they came then up with this cut point that showed a very good sensitivity and a very good specificity, and they were able then to allocate patients in a good and a bad prognosis group. And this 70 gene profile has also now come into market. It's marketed as Mallmann, and it's very successful right now. They even started a trial with that. It's called the MINDEX trial, where patients are evaluated according to their clinical pathologic factors, but additionally a 70 gene signature is established, and patients going to switch into different treatment arms whether or not the 70 gene signature shows a low risk or a high risk, and the clinical pathologic signature shows high or low risk, and patients then are allocated to different treatment groups. So this is the first trial that uses a prognostic gene expression profile, takes it into the clinic, and evaluates its prognostic factors. So, just 4 to 5 years after several prognostic profiles were published, people tried to use these gene expression profiles to use it as a predictive model to see whether certain patients with certain gene profiles respond differently to chemotherapies. And that's just one example. There are a couple of papers out there, it's about 60 to 80 papers that are just focusing on predictive gene expression profiling in breast cancer and chemotherapy. And this is just one example to show you where the group of De Lorenzi used a stroma-related gene expression signature that was able to predict resistance to neoadjuvant chemotherapy. And they're not only able to show that it has a predictive effect, which is seen here. So these are two different samples of patients from two different cancer clinics, but it has also prognostic impact. And what you can do for neoadjuvant chemotherapy, you can easily also do for response to endocrine therapy, and also this test, which was published in the New England Journal, is now brought into market. It's called Oncotype DX, which initially was only for node-negative and estrogen receptor-positive breast cancer, but now it's extended also to node-positive breast cancer as well, and it takes into account several genes, or the expression of several genes that are related to metastasis. And also for this test, as it's coming into market, there's a big trial on the way right now, the so-called TELEX trial that allocates patients according to their recurrence score. A recurrence score under 11 will only lead to hormonal therapy, whereas patients with a high-risk recurrence score of over 25 are giving chemotherapy, and the intermediate group is either giving hormonal therapy or chemotherapy and hormonal therapy. So altogether, what might be the future is that a patient that comes with breast cancer into your clinic gets a gene expression profile. You either allocate the patients according to their prognostic gene expression profile, or you use or anti-use the predictive gene expression profile to allocate patients to certain chemotherapies where you know that they're very likely to respond to. So I showed you the past, I showed you the present. We in the Life Medical Science Institute think that that the future will go from the glass slide-based microarray gene expression profiles to the next generation sequencing machines, which are already now called generation sequencing, that not only give you an expression value of genes and a gene expression profile, but also gives you all of the mutations, all of the fusion genes, and all of the alternative splicing events in the cancer cell. So we believe that this is the future. It's even getting much less expensive. It's around 1,000 to 2,000 euros at the moment, and the prices are dropping down for that too. So we believe that this is the future, and that the gene expression profiling, although it was very interesting and very dominant now for the last 10 years, will only be used in some niches, but we will certainly go for the tumor genome in a day and then allocate persons or patients even more personalized to different treatment groups. Thank you.
Thank you, Dr. Mallmann, for an excellent presentation. And if you have not read the paper yet in the journal, I recommend you do so. It is an outstanding paper. As a matter of fact, the journal and the board has denoted this particular paper in this presentation as a distinguished article. And I'd like to give this presentation to Dr. Mallmann.